Our first guest today, the host of this event, is Mika Pollack, BS MPH. She's a board member and executive director of Safest Drug. She's a former mental health counselor and operations leader for private pharmaceutical company funded clinical drug trials. We have David Carmichael, BA MA. He's the executive director of Canadians for Vanessa's Law, which developed Know Your Drugs global awareness campaign in collaboration with RxISK. And last but not least, Erica Komisar, LCSW. She's a psychoanalyst, author, and parent coach. So welcome everyone. I want you each just to go around and kind of say a little bit more about yourselves and your initial reaction to the film. Mika, you want to go first?
Sure, I'll start. So first, I want to thank everyone for attending Safest Drugs Medicating Normal event tonight. And thank you, Angie, as well as Nicole's not here, I think, on the call, but she was also very instrumental in helping to arrange this event. And I want to say that I think there's many takeaways that all of us can have from the film. But if I were just to pick 3 key takeaways, I would say what I walk away from when I finish watching this film is, first and foremost, when you look at the stories of the people in the film, I think about how folks who are going through the healthcare system and taking medication and getting prescribed as prescribed are having impacts and effects that may not always be caught, right? So, I heard more than one person mention how, their voices weren't heard, their testimonies of how they were feeling. One thing that is very striking to me as someone who's worked in research in looking at the patient care story and the perspective is that when we study patients or subjects in the clinical trial world, we are doing a lot of monitoring. We're doing a lot of lab work. We're doing surveys. We're constantly on those subjects as they're taking what they call the investigational drug product, the IP. We're paying attention to what is happening to the person's body as they're taking a medication, but you don't see that in the real world. And I think that this film really captures that very beautifully. Of course, we're led by lots of standards of care, and we're led by the fact that, we have a very high prescribing environment in the US, but that's the biggest difference that I see is that we don't have a lot of monitoring. Another key takeaway for me was the lack of education. So more than one person mentioned, and this is something that Safest Drug has also wanted to get behind, the fact that patients should be receiving informed consent or advanced education around their medication, right? So as you mentioned yourself in the film, you're not anti-medication. We take the same stance at Safest Drug. We're not anti-medication, we're anti-medication harm, and we want to look at it from a public health lens. So part of that strategy is thinking about education as a prevention tool, right? And so if we can actually talk to people about their medication at the point of care, as they're getting prescribed, we can educate people about what could possibly happen, make them more informed, and even talk about the possible alternatives and the safe use practices. And then the other thing that really I took away from this is the fact that, and I'm thinking about from a public health perspective, if we were to say right now, today, this moment, who do we go to right now to understand how many people, let's just say in the US, are taking a benzodiazepine or psychiatric medication, right? And out of that number, how many people have been harmed? And what are those harm outcomes? What do they look like? Where can we go? We have none of that information. So again, we don't have great surveillance. So from a public health perspective, we're unable to even determine with great accuracy the prevalence and the incidence rates of as prescribed harm, which complicates the issue. And so you see people even in the film leaning on each other, forming support groups, talking to one another, trying to get through this, but also where are we capturing the actual outcomes? What's that database? What's that source? We're not doing that. And so I think that the film does a beautiful job in capturing the perspective from the psychiatric drug realm, but there's so much around medication harm overall that we're not doing in this country, and probably in many countries, that we can do better. And so I think for me, as I watched the film, my biggest takeaway was, what are the prevention steps? How do we solve this problem? How can we make it better?
David, would you like to go next?
Sure. I'll first just provide a bit of explanation on Canadians for Vanessa's Law. Vanessa's Law is the Protecting Canadians from Unsafe Drugs Act, and it received royal assent in Canada in 2014. And Vanessa was a young woman at 15 years of age. She died of a heart attack on a drug called Propulsion in front of her father, who became a member of parliament and was the driving force behind what is now Vanessa's Law. Our charitable organization, our mission is about informed choice in terms of prescription drugs. It is really about informed consent, which I heard several times during this amazing film that everybody needs to see. And I think what this film will do right from the onset is make people recognize that if they've started a medication and their symptoms get worse, it might not be them. It might be the drug, because if they go back to their family doctor or their psychiatrist, it's quite possible that they'll wind up being prescribed another drug to deal with the side effect until they're on several drugs, which, as you can relate to. I really think this is a must-see film. On a personal level and on a professional level, Know Your Drugs is the first project of Canadians for Vanessa's Law. And it's also a very simple message that to me has tremendous personal implications, because I knew nothing about Paxil, even from my family doctor when I was first prescribed it in 2003. I went in, I got a prescription, I got a printout from Shoppers Drug Mart in Canada. It really said nothing, certainly nothing about suicidal ideation or any of the suicidal risks. I started taking it for mental distress caused by cash flow worries, which so many people are now dealing with because of the COVID-19 pandemic. So I'm now moving now with knowyourdrugs.org. I've got a presentation online, plus I have my own story and a document called Paxil on Trial within a presentation section on the website knowyourdrugs.org. And I was on the drug for 8 months, and I was able to pick up some contract work and things were going well, and I missed taking it for a few days. So I decided, after doing a bit of research, my background is in research and development, predominantly within the school system in physical activity and sport. And I did taper myself off of the drug over 5 weeks. I know I had to do it slowly, and I could not find anybody who knew how to deprescribe. All they knew how to do was prescribe. So I came off of the drug, and I was quite good for 4 months, but I had a lot of contracts. And I became sleep deprived because I was directing a brand new summer camp in the city of Toronto in Canada, a really large city. And I wound up going through some very similar symptoms, which is more distress related. Anxiety, I couldn't sleep, so I moved my bed downstairs. And I had a full prescription of Paxil that my doctor had given me. And again, every time he filled my prescription, never talked about one side effect. So I put myself back on the drug at 40 milligrams. And it was the very first time I experienced akathisia, which is real irritation, irritability, and suicidal ideation. And I experienced it right away when I was sleep deprived. So within the first week, I decided I would increase my dose, that the problem was me, and like taking 2 aspirin instead of 1, I could get rid of the suicidal thoughts. Again, there was nothing in print. This is now July 2004. And I became psychotic. I went from being suicidal to planning a murder-suicide. And on July 31st, 2004, in a psychotic state, I took the life of my 11-year-old son, Ian. I was charged with first-degree murder, and I went through the forensic psychiatric system in Canada. And fortunately, now I've been off all medication and no therapy. I've been trying to just work hard to rebuild a life over more than a decade now. But I'm not anti-medication like the rest of you. I just believe you have to know your drugs. And sometimes you have to do your own research, because many doctors simply learn about the drugs from the pharmaceutical sales reps.
And Erica?
That was a powerful story. So, I mean, the film impacted me. It was powerful, really, for me, because what I do as a psychoanalyst and psychotherapist, and someone who specializes in helping families with their children and teenagers who are suffering from anxiety, depression, and diagnoses of ADHD, is help them to really understand what those diagnoses are. As a psychoanalyst, we actually don't diagnose people. We treat people with talk therapy. And So, you know, in a way, I think our culture has moved towards, and what the film sort of reinforced was that our culture has moved towards the quick fix society. And it means that, you know, it's about symptom relief rather than really understanding that anxiety and depression and ADHD are disorders of emotional regulation, which have to do with psychosocial stressors. So a lot of the people in the movie, you know, we got some background, and Angie, you're so brave to make this movie, be in this movie, you know, get this movie screened. I really applaud you. But I think the idea is there's a real misconception of what anxiety, depression, and ADHD actually are. I wrote a book that came out about 3 years ago called Being There, Why Prioritizing Motherhood in the First 3 Years Matters, which was based on all the neuroscience and epigenetics research, very research heavy book for lay people though, so they could really understand where these disorders come from. They are not, for the most part, genetic. They are not in your blood. They are not something you are born with and you are stuck with, for the most part. There are rare exceptions. There are schizophrenia, maybe a rare exception. Serious bipolar disorder may be a rare exception where there's some sort of more of a genetic link. Otherwise, we say it's called the inheritance of acquired characteristics, which means that stress in our environment is about 90% of what causes our emotional dysregulation. And most psychiatrists aren't trained to understand that. They are trained to believe that it is a brain disorder, you are born with it, it is you are always going to be like that, and take these pills just to get rid of the symptoms. And that's just incorrect. It's incorrect from every piece of research that is out there. But that is how they are trained. So they do say those things to patients, but it just isn't true. So what we understand is that there is a genetic piece to these disorders, which is we are either born sensitive or less sensitive to stress in our environment. There's something called a short allele on the serotonin receptor, and there's research to show that many, many babies are born with that short allele, which means that they're more sensitive to stress and therefore more prone to things like anxiety, depression, and ADHD. So just to define again, the overdiagnosis of ADHD. Okay, nobody wants to know what that's about, but really what it's about is the hypervigilance of the brain in response to stress. So the brain goes into a state of hypervigilance in response to a stressor. In the case of the military, that stressor might be a bomb exploding with your friends in a truck. It could be abuse in childhood. It could be being raped in adulthood. It could be, there's such a variety of losses and traumas that people don't connect to their emotional dysregulation issues. And, there's also a vast difference, should I say, between, I just wrote a piece for the Wall Street Journal, there's a vast difference between unhappiness and distress and depression, right? And the movie really made that clear, which I think is really important, that we're a culture that is uncomfortable with discomfort, right? And so the idea is just get rid of all the discomfort, but discomfort is part of the human condition. Pain is a signal feeling, which tells us if we're in emotional pain, that we need to look at ourselves and look at our environment and look at our relationships and look at our history. And we don't want to do that as a culture. We just want to fix it and get rid of the feelings. The problem is the medication only does that if it does that short term. So it's a culture that is not curious about the origins of things. And that is deeply disturbing to me, because children are being diagnosed and misdiagnosed with things like ADHD, which is really truly underneath anxiety. So why not treat where that anxiety is coming from with talk therapy, with alternative healing methods for emotional regulation, like meditation and mindfulness training, and even exercise. I have a colleague who wrote a book about the importance of physical exercise and acupuncture. And, talk therapy is really about respecting and addressing our feelings about loss. and our feelings about the trauma we've encountered. Whereas psychiatry has, and I don't mean to demean psychiatry, because I have a lot of psychiatrists I work with and I respect a lot. And some psychiatrists are psychoanalysts who have foregone the medication and really taken up the mantle of talk therapy. But, for the most part, psychiatrists, you can't blame them. They are really trained not to understand the importance of pain as a marker of something much deeper in us, that anxiety has an origin, and we want to get to the origin to really address the anxiety rather than diagnose someone with hypervigilance of the brain. And we call it fight or flight, right? We all know what fight or flight is. That's what hypervigilance is. In the face of stress, either current stress or a past stressor that's come up, like PTSD is a past stressor. We either fight and get aggressive, or we flee, which is what distractibility is about, right? So at the core of that is really what we call hypervigilance and hypervigilance, depression and anxiety. So if we move away from this very superficial approach of just relieving ourselves of discomfort and symptoms, and we really look deeply at what is causing those symptoms, and we encourage people to talk about their feelings. So one thing I'll say about the film is, and I know it meant it, but I'm going to say it, which is you can't take away medication. You don't even want to prescribe medication as a first stop. You want to prescribe it as a last stop. So I am not anti-medication. I am one who believes that medication should be your absolute last stop on the train when you've tried everything else. And then it should be used as a bridge to health while you are understanding where those symptoms come from. But it is not a substitute for understanding where our feelings come from or expressing our feelings. And that is something that psychiatrists are not trained in.
Very good comments from everyone. We have a lot of questions coming in, but I want to ask one question first before we jump into the Q&A, and it's for Mika. If you look at the Safest Drugs website, you talk about a public health problem. Can you talk about what that means? Like, what are public health approaches to medication harm? Can you just frame that up for the audience? What does it mean by taking a public health view of a problem?
Sure. So we were inspired for a number of reasons to do the work that we're doing. But if we take a look, just for example, at the FDA and at least the adverse drug reactions and events that they monitor and they collect over the span of a year, we're looking at 2 million plus in 1 year, just last year alone. This number, by some experts, has been estimated to be less than 5 or 10% of the actual number, right? And so we also know that every medication comes with side effects, both known and unknown. And we learn about these through the life cycle of the drug on the market. So if we look at harm as just something that basically happens when someone either is injured or they die as an outcome from taking a medication, we realize that people die for many different reasons. So some people, and this is what the film focused on primarily, they die or they become injured from a medication by taking it exactly as prescribed. Well, there's other reasons. Some people accidentally ingest the medication. Some individuals receive the wrong medication. They call them medication errors, for example. So there's many ways that people die and become injured. And so when we looked at this from a public health perspective, we did that because if we think about some of our biggest public health problems right here in the US, let's just take gun violence, for example. We see that on a national stage, people consider gun violence to be a public health crises that kills an estimate of 40,000 people or so every year. But when you look at the numbers, which I would say kind of varies depending on the source you're looking at, people estimate that over 100,000 people are dying every year because of a medication. And so to us, if we consider 40,000 deaths to be a public health problem, we absolutely should look at medication harm as a public health problem too. And so when we look at it from a public health perspective, we want to deal with the primary preventative steps to solve the problem, and also think about the people who are harmed. And that's why we also want to alleviate the problem. And we want to do this with education. We want to do this with grassroots research and even advocacy and support. And so when public health people go in to solve a problem, take COVID-19, for example, we want to know how prevalent is the issue? Where are the cases? Who's getting harmed? Why are they getting harmed? How do we identify that? How do we make it better? How do we prevent it? So that's kind of the perspective we take at Safe-ish Drug with the work that we do.
Perfect. I just wanted to make sure everybody knows what that meant, because public, it's just great to talk about that. Okay, so for the first question, I think all of you could probably answer this in your own way. And to be honest, it kind of rubs me the wrong way when I get this question. So I hope that we can have a good conversation about it. So the questioner says, I wonder why individuals that are prescribed drugs do not do their own due diligence before taking them. I have always believed that one must take responsibility for their own psychological health. So can we talk about what exactly is included in the FDA pamphlet? What do we know about a drug when it goes to market? What do patients know about when they read the pamphlet, and what do they not know? Could you each kind of discuss that?
Well, I'll be happy to start off. I think there are a couple of things. Is blind trust of doctors. You know, I mean, in 2003, I just trusted my doctor, that my doctor was properly trained and knew everything they needed to know about the drugs that he was prescribing. And, you know, I learned the hard way that that's just not true. The influence of the pharmaceutical industry on education within medical schools, I think there's several books have been written on that alone.
I'd like to add to that if I can. You know, it really sadly depends on, almost by luck, where someone ends up. If someone ends up with a therapist who is not pro-medication, isn't anti-medication, but isn't advocating for medication, a psychoanalyst or a psychotherapist or a talk therapist, they're likely to be less channeled into that kind of tunnel of medication. And I think there's a mistaken belief in this country that psychiatrists are better at therapy, are better with mental health because they have an MD. And in fact, I just want to correct that and say that psychiatrists are, for the most part, trained as psychopharmacologists. That means they're trained to medicate away symptoms. They have very little, if any, clinical training. That means going to a psychiatrist for talk therapy is not, they don't have training, most of them, for talk therapy. Most of them have never been in any kind of mental health treatment themselves, right? So to go into the field of mental health, you have to have had some pain in your own life. You wouldn't go into that field. And unless you've been treated yourself with some form of therapy, you are treating patients without having been treated yourself. So part is in, the problem really is in the fortune, the good fortune or bad fortune of where you end up being referred to by a friend or your pediatrician. If you end up at a psychiatrist's office because you think just by virtue of their MD that they're better at treating mental health, you're gonna go down that tunnel. So I always say to people, don't go to a psychiatrist first. A psychiatrist should be your last stop if you need medication. Go to a talk therapist first. And I want to emphasize that again because the movie did mention it, but not as intensely as I want to say this. A lot of the people in the film, what I felt was missing is that they had been channeled into this medication tunnel and not given talk therapy first to see whether they actually even needed the medication. So it's sort of by accident where you end up.
And I will say that my answer to why people don't do their due diligence is, I think, for many, many reasons. So on the one hand, I would say that if you were to receive something, regardless of a medication, any kind of product, and no one that you're getting it from emphasizes issues and raises a heightened sense of concern for you to watch out for certain potential risk factors, chances are you're going to lower your guard. And as David mentioned, you know, there's this trust. We have this societal norm that a medication overall is a good thing, right? I mean, it has a connotation that this is here to help you, not to hurt you. And so it's very controversial to think about a medication that's doing something harmful to a person. But, you know, people who receive these medications at the point of care, at their pharmacists, when they receive these medications, they come back with all this literature. If you receive all the literature, because people don't receive the same thing. Not everyone receives, for example, a medication guide or certain patient inserts or leaflets, depending on where you are and the medication you receive. But when you get that, people don't always read all of that. And then we have to think that some people, may not be able to understand that and digest that. So we don't even think about the fact that there could be just comprehensive issues and people not really understanding what's relevant that needs to be read. Oftentimes, I don't know about you, but I've been at the pharmacy for my kids, myself, other family members, and normally you're there for an emergent issue. You're sick, you need to take medicine. You get home, you take it right away. It's not about, let me sit down and take 20 minutes, an hour, do my research, pull out my glasses, my magnifying glass, and read the tiny insert language. And so I think because the delivers of medication kind of lower the bar in educating, then we almost kind of lower the bar ourselves, I feel like, in self-educating.
Yeah, and I'd just like to add, my answer to that question kind of varies, but I feel like even if you do your due diligence and you read every word of that medication guide, first of all, they only do studies like 8 to 12 weeks to get that printed. So they don't know what's going to happen long term. So a patient can read that and be fully informed and still not know exactly what's going to happen to them when they're on it for 15 to 20 years. Also, I think it's almost impossible to give fully informed consent because like the withdrawal is barely brushed upon. It seems to be downplayed of like what people are really experiencing as a long-term outcome. So I just want to say that too, that I don't think it's even possible to get fully informed consent because we just don't know. We don't know how these drugs act in combination. We don't know about long-term, all these things. So let's see, there's a lot of really good questions. People are asking about, right now, like with the opiate crisis, there's people are moving to methadone, Suboxone. So now there's another set of people on more pharmaceuticals. How does that impact like the public health, people on those pharmaceuticals? Another person's asking about what proportion of people who take benzos suffer from withdrawal symptoms. Can you talk maybe about, that it's not just psychiatry, that it can occur in other things?
Yeah, so definitely other drug classes have been linked to negative health outcomes. So I've been in patient groups that center around whether statin drugs or antibiotics, certain dermatology medications, you name it. These medications are very strong, highly potent chemical compounds, and they can react in very unpredictable ways based on the individual. And so I think that what I remember from research is we look at the problem as most of the people may have a good outcome, and we have this small portion of people who have a poor outcome, but they're small in the sense that there's more of a benefit than not. So we move forward, right? So it's almost like the individuals that may be experiencing harm almost become, casualties of the process. We kind of minimize that. That's just a small chance. Those are rare outcomes. And it's almost like we kind of ignore that problem. And so I would say that with regards to, understanding, again, the full scale, so one of the questions was, what percentage of people actually experience these withdrawal symptoms? I don't know that. And I don't know if anyone actually has the actual number of that because we don't have required monitoring. When you're in a clinical drug trial and you're testing a drug, you're required to monitor, you're required to document. But in the real world, in the patient care setting, you're not required to call patient X and say, hey, you've been taking this drug for 2 days. How are you doing? And let me document this. You're not required to say, come in here now and I want to take lab tests on your blood work and check your kidney and your liver levels. So there's all these things that we don't have to really understand the full scale of it with regards to withdrawal symptoms, I think. But you may know a little bit more too, Angie, because you're connected more with the community, the benzo community. But at least from my perspective, I haven't come across any reliable, full set data.
Yeah, the only thing I can say about benzo data is recently, within the last month, the FDA actually put a black box warning on benzodiazepines. And believe it or not, me and 4 other women laid in our beds in benzo withdrawal, typing up MedWatch reports on the FDA's website, reporting adverse reactions from our community. And we had about 1,400 reports in a very short, maybe 6 months. And the FDA just released that they put the black box warning on from our advocacy. So you know, the other thing about this is it's tricky that a drug can work for you for 6 years and then one day it doesn't, and you become one of the statistics. It's not a static thing. Our bodies are always changing. So you could be helped for a long period of time and then harmed.
Angie, I just want to make one comment on adverse reporting. Part of knowyourdrugs.org, we have a portal where you can research drugs in different countries through the government regulators of the pharmaceutical industry, plus RxISK.org, which is an independent international website. And we also have links to reporting, because right now in the United States in 2019, 95% of the reports of the FDA came from the pharmaceutical industry, and they're mandated to report. We need consumers and their parents, guardians, caregivers submitting reports overwhelming the government regulators. That's critical. I mean, you've just seen the outcome of that. Could you imagine if people that had adverse reactions started to report them to the government regulator? We might actually see a movement that is long overdue.
Yeah, it's publicly available to read the MedWatch reports on the FDA's website. I heard from someone who works in Washington, D.C., who writes a bulletin about drug practices that says, like, the FDA, there's not even a mechanism to really read those things. But they obviously did read the benzodiazepine reports and recently updated that. But it's free for anybody in the public to go read the reports. And you'd be astonished what you read on some of these drugs. But the other thing is that it's like a very, very small percentage are actually reporting their adverse reactions. So we don't exist, really. These problems don't exist if people aren't reporting them.
Right, exactly.
Right.
So you cannot say you have a problem if you can't prove you have cases, right? You have to test, you have to monitor, you have to report. And so I'm so glad that David said that, because that's a huge part of the work that Safest Drug wants to do, is we want to increase detection. So we have to get consumers to talk. Healthcare providers are also not required to report. As David mentioned, pharma companies are only required, at least here in the US. And so therefore, we may face a bigger, hill to climb there, just because at least a lot of the healthcare providers I speak to, they don't have the time built into their regular day-to-day to be able to do those reports. And the process of monitoring is just not there at the patient level with the provider. But consumers and patients can absolutely do that. And if we just had even a 10% increase, right, of more reporting, we enable the FDA to be so much more empowered and capable to detect safety issues much sooner than we're doing right now.
If I can make just two final comments around this, because I think this is such an important topic. I think people need to report suspected adverse reactions, because one of the things the pharmaceutical company is tremendous at doing is denying any causal relationship. They deny causality all the time. They protect themselves that way. Man, I'm in a lawsuit against GlaxoSmithKline right now, and they are denying causality that Paxil caused my psychotic episode. So, that's one thing they've become very good at doing. So if you suspect it, you may not necessarily, if there's a way to find out and do some research, if you go back to the doctor, there's a good chance it might be prescribed another medication to deal with that side effect. That side effect needs to be reported, and you're not going to be able to prove it. Like it's got to be suspected. It's got to come to your gut. Some people claim, submit around serious adverse reactions. Well, that's an individual thing. These drugs cause death, disability, and dysfunction, and all those things should be reported. Dave, when he was talking about sexual dysfunction, that needs to be reported, and I'm sure he hasn't reported it. So, this needs to be reported. So what you've done with the FDA, Angie, is great. More people need to do it.
Yeah. The next question, I'm gonna pass it to Erica. Erica, I read your article in the Wall Street Journal about children and ADHD while the film was playing. And there's a question in the audience too, kind of similar. It's about how can an LCSW or LPC or a therapist give informed consent? And specifically, I want you to talk about like teens and adolescents and children being prescribed the drugs, and like how you can coach parents through that process.
Well, I mean, again, the first thing I do with the family is, I almost wish, in a way, Mika, that you had something on your website that says therapy first, talk therapy first. Always go to a talk therapist first. That should be your first stop. You may never have to get to a psychiatrist. That's the point. But when you say, explain to me what you mean by informed consent in that question, so I understand the full.
Her question is it ethical, or I'm not sure if it's a he or she, is it ethical for an LPC or LCSW to provide informed consent information on psychiatric drugs, even though we are not licensed to prescribe
Yes.
meds?
Got it. The answer is, it depends on how much research you've done. I did 13 years of research. I didn't do the research myself. I looked at every research paper on the subject of mental illness and emotional regulatory issues with children and adolescents. So it depends how informed you are as a clinician. I mean, I am incredibly informed because I write books based on research. So if you're curious as a clinician, you do your research, you look at the neuroscience, you look at the epigenetics, you look at the attachment research that talks about the origins of things like depression and anxiety being in early attachment issues that makes us more vulnerable when bad things happen to us in life, meaning our resilience to stress is based on whether we had a lot of secure foundation in the very beginning. So, you know, as a clinician, I don't feel it's responsible to practice unless I understand the implications of the neuroscience piece of it and also the medication piece of it. So I am not anti-medication, by the way, but I am pro talk therapy first. And if that isn't enough, or if someone is harm to themselves or others, a teenager or an adult, then I'm not anti-medication. But again, the way I think about medication is it's a bridge. And so, yes, I do inform my patients based on, I'm a psychoanalyst, but I also talk a lot about the research to my patients. I say, look at this research. And that's the advantage of going to someone who's not a psychiatrist first, because they're going to get you to be curious and question things. That's the issue. We have to question things. We can't take it verbatim from a doctor. We have to take that and say, this is information. Now I'm going to go do my own research. Doctors aren't God. They are just one piece of a very big puzzle.
If I can make a comment again on Erica's comment, you know, when I went and saw the doctor, I was told I had a chemical imbalance in my brain and that Paxil would correct it, which is really the only reason I took it. I actually thought it was biological, genetic, and I needed to take the drug. And if I'd have known, at the time the research was there, but it was what we would call fraudulently concealed, which means it was hidden by GlaxoSmithKline. If I was known that there was a possibility of suicide and or homicide, I would not only have not taken the drug, I would have wondered why it was ever on the market. But I didn't have that information. So I've made some poor choices. And I hope that information is out there now and people do their own due diligence, as one of the questions pointed towards, the importance of it.
Can I just say one other thing, which is due diligence for an LCSW or an MSW is there are courses that are taught by psychiatrists who are psychopharmacologists where you can get continuing education credit. And I think it's irresponsible to practice without taking those courses as a CSW, because you do need to know the lay of the land, but it also gives you an opportunity to ask questions about the side effects. So you need to be informed. If you're going to treat people today with emotional regulation issues, you need to be informed about those medications. I mean, I'm just finishing a book that's coming out in September for parents of teenagers to raise resilient teenagers in this age of anxiety. And there's a whole chapter on the medications and what they do and the side effects. And you have to be informed as a clinician so you can, quote unquote, warn patients about it.
Yeah, so next there's a few comments kind of pointing to like legislative priorities to, somehow fix this problem. A little bit about the pharmaceutical corruption where, the trial data is not showing like the negative trials, only the positive trials are being, given. So can we maybe touch on that a little bit about research, pharmaceutical corruption, and legislation?
I'll talk quickly about Vanessa's law. And this she put into perspective in Canada. Prior to Vanessa's law, which got passed in 2014, if Health Canada had picked up some information about possibly even, hidden data or clinical trial data not being shared, and they went to the drug company and asked for them to change something or do more research. If they did not comply, the penalty was $5,000 a day until they did comply. With Vanessa's law, it is now $5 million a day maximum plus prison time. So Health Canada is finally taking this seriously. Our challenge is, from a legislative point of view, is implementing the law. Now we've asked hospitals to report any serious adverse reactions within 30 days of the incident being reported. I have no idea what those numbers are like. That was passed as a regulation December 16th of last year. So I'm going to put in what you would call a Freedom of Information request in Canada on December 17th to find out how many hospitals actually reported serious adverse drug reactions in the first year. But I think it's enforcing these laws that is a challenge, because the lobby of the pharmaceutical industry is so powerful. We talked about the billions they spend on this. And, for people who've been harmed, which usually they're the strongest advocates, the people who've been harmed, we really are. It's a tough battle.
Anybody else have a comment?
Just a tailspin off of what David mentioned about people who've been harmed. I think that one of the biggest challenges is in the predictability or the lack of predictability in drug response in individuals. This is what we saw a lot in clinical trials. It's something that we see quite often, even in the real world. And it's very hard and difficult to show causality, to say that that drug caused that problem, particularly when you're on many different medications, right? So we talked, the film hinted at polypharmacy, a person being on multiple medications at the same time. That complicates things. And this is why even in the clinical trial world, we make sure that certain patients, depending on the protocol, they can't even be on a whole list of medications because it's going to bias our interpretation, our analysis, right? And so I think that when we think about predictability and causality, I think that's the hardest part around getting our arms around medication harm, particularly for the as prescribed population segment. Other issues are a lot less debatable, right? So you can look at organizations around the country that deal with accidental medication overdose with children. If you leave a prescription bottle on the counter, no one will dispute that that's wrong. No one will dispute that there should be intervention for that. But there's something about prescribing a medication in the clinical setting, in the real world, post-research, post-FDA drug approval, that is just very hard for us to kind of modify the approach and the language around how do we treat patients and who do we end up, listing as the causal factors. I see this as a very systemic issue, but there's definitely preventive steps we can take. And I think education is one piece, but also what David mentioned and what Vanessa's law has done is really use advocacy and changing of legislation and policy to also protect individuals from harm.
I also want to say that, we can't deny that it isn't just the drug companies. It's a collusion with educational institutions and MDs. I mean, one of the issues too is that many children and adolescents and adults never even see a mental health professional when they're prescribed these medications. They're prescribed by their internist. An internist doesn't know anything about these medications. It is not their specialty. And so I think the statistic is for children and adolescents, 1 in 5 children in America have some form of mental disorder. 1 in 10 children in America are on some psychopharmacological medication. And only half of those 1 in 10 actually ever see a mental health professional. So there's a collusion, I think, that we can't deny. Teachers and school administrators just want students to act correctly. They don't want to understand the psychosocial stressors on that child that are causing them to have behavioral issues or causing them to have distraction issues. They don't want to understand. They just want them to behave and learn. MDs just want people to feel good. And so there's a kind of collusion, I think, with some of these institutions. It isn't just the drug companies. The drug companies are offering, the drugs, but then why are we so quick to grab them? right? So that it's sort of the societal collusion, if you will.
Yeah, thank you for mentioning that. I think I'm mindful of the time. I don't want us to sit too long, but I just wanted to say there's a lot of really good questions. I can't get to all of them. There is a lot of people in the chat box that are talking about, they've been on medications long term. They definitely feel like it's harmed them. They're having trouble coming off. So I just want to give it, say that we see you, that we know this is a very stigmatizing issue, like Mika kind of touched on earlier. To say that you're on psych drugs is one thing, and then to say that you're harmed by them, it's almost taboo, especially these days. So we hope that the film can bring attention to this problem. Let's just go ahead and we'll go around one time for closing thoughts. Talk about where people can get in touch with you. Maybe one nugget of advice that you would give to empower patients to, be more informed consumers, and closing thoughts. You want to go first, David?
My message is know your drugs. And, if you visit knowyourdrugs.org, and you go to the presentation section, you'll see a presentation that I've just posted. In fact, I recently posted the presentation plus a 2-pager called Paxil on Trial, which explains my story. To make sure that it was done for tonight, I talked to Mika earlier today. And, over the last several months, she's been talking to me about the presentation I've been working on. And I've been working on it for close to a year and done tremendous testing with it and comfortable with it. And then I've added the 2-pager because it's very hard to explain my story, during this, during a discussion like this. And it's a 2-pager, but I'm one anecdote. But I would like to think if people read through this, that I had a really bad year in my life from July 2003 to 2004 on Paxil. And my son is dead because of it.
Should I go next, Angie? Or
Sure, yes, please.
I want to address that issue of people having a hard time getting off these medications. And, emotional regulation isn't something that we are as human beings meant to do entirely on our own. We're not born in this world as infants with the capacity to regulate our emotions. We get that regulation and internalize it from having had it in those first 3 years from whoever cared for us. And if it didn't go so well, or we had terrible traumas along the way, the idea of doing it on our own isn't really, it's not realistic. So I think of getting off of medications, which are really substituting for emotional regulation. Think of it like substituting. You have to substitute that. You can't give up one thing without replacing it with another. I think of it like driving a shift car. If you take your foot off the clutch and you don't put it on the gas, the car stalls. So you have to replace, you can't just stop the medications. You have to replace those medications with talk therapy, yoga, mindfulness training, meditation, acupuncture, nutrition, massage, all kinds of things that we know based on research today do the same thing that the medication does. Human contact does the same thing. That's why talk therapy is a little harder now, because we're not physically in the presence of patients. But the concept of being in the presence of another human being who can help to regulate your emotions. So what I think my message would be, don't think of this as on or off. It's not quite like that. But if you're going to get off of these medications, then you have to substitute them and replace them with something better.
In my closing thought, Angie, is really simple. First and foremost, I want to thank both David and Erica for taking the time to be on the panel. I also want to thank you, Angie, and the entire Medicating Normal team for helping to pull all this together, for all the work that you're doing. I know you have plenty more screenings ahead of you. Hopefully you can stay resilient and strong through those. I also want to thank our volunteers, all the volunteers who helped to kind of, share this event with their network, our social media volunteers as well. And I want to do a special shout out as well to our board of directors who supported this movie from the very beginning, from the moment you sent us the private trailer and the screening. They really enjoyed the film. We were super excited to get behind it. And I think my one take home message for the audience is to visit our website, safestdrug.org. We have a resources page with tons of different links that I guarantee you'll find at least one that you can use. And again, as David had picked up on and mentioned first, and I kind of piggybacked on that, if there's one thing that you really can do to help the medication harm problem, and that is really to get behind reporting, suspected and confirmed adverse drug reactions, as well as product issues. The FDA, they want to know, they need to know. They're the only federal agency that has the responsibility to monitor this. It's not the CDC. They will at some point, receive data and understanding of the issue, but it's really the FDA. And so we can't do anything to identify a problem if we don't get people to talk about the problem. So that will be my take-home message more than anything else.
That was excellent. Thank you all. Yes, thank you panelists. Thank you audience members. Thank you for joining us on Giving Tuesday for Safest Drug as the beneficiary of tonight's proceeds. I'll just say one last thing about the film. We are in distribution negotiations for US release. European release will be first. So we continue to do these community screenings with nonprofits and other hosts. So you can visit our website, it's medicatingnormal.com, for more chances to see the film or to share it with your networks. We also have a reading list. We like to say, don't believe anything we say. Go, let this be the beginning of a conversation in your own life and on your own journey toward more empowered health decisions. We have a YouTube channel with over 100 clips that didn't make it into the film and about 30 screening panels just like this one, all on different topics. We post articles daily about these subjects on our Facebook and Twitter and Instagram. So the education's out there. Please follow us. Please like us. Please subscribe, all that good stuff. And thank you all. And I wish you all the best holiday season possible, whatever holiday you celebrate. Thank you,
Angie.
Thank you.
All right. Have a good evening.
Bye. Thank you.